Welcome to my channel. Today we will discuss a few ECGs in anterior wall myocardial infarction. We know that ECG is the best test for early diagnosis of acute myocardial infarction, even though there are other confirmatory tests and also tests which can be considered when the ECG is not diagnostic but clinical features are suggestive of acute myocardial infarction. There could also be situations like post-operative patients where there will be no symptoms. Myocardial infarction can be detected by just a routine ECG. So we will go into the details of findings in this ECG. This belongs to a person with acute myocardial infarction but not hyperacute myocardial infarction. Hyperacute means very early stage. This is a little more delayed because the T waves have started getting inverted. QS complexes, QS complex means just a Q wave without an R wave, have appeared in V1, V2, V3. V4 there is a tiny R wave. V5 there is R wave. V6 also there is a good R wave. Then ST segment is elevated. In V1, it is an upsloping ST merging with the T wave. This is the type of ST elevation seen in hyperacute phase, but not like this. The ST will be a little more marked and the T wave will be tall. Tall T wave will be noted in hyperacute phase, mainly in these leads. And ST elevation in anterior wall myocardial infarction is usually maximum in lead V2. ST elevation in anterior leads can also occur in right ventricular infarction, but in that case it will be more in V1 compared to V2. And if you take right just leads, V3 or V4R, there will be ST elevation there also. Here T wave is inverted in lead 1, AVL. AVL there is also a small Q wave. AVL is suggestive of lateral or high lateral, I would say. And T inversion is seen. T has partially got inverted in V2, V3 and V4. When the T gets inverted, V5 also there is T inversion. ST becomes chord. This is the chord ST elevation. Chord ST segment elevation. We should be detecting myocardial infarction before the coving has occurred. In the early phase, hyperacute, when the ST is upsloping and probably slightly concave upwards. This is convex upwards. Early detection is important in early treatment like thrombolysis or better primary angioplasty. Open up the closed vessel at the earliest. So this is anterior wall myocardial infarction. Then there is slight negativity of the terminal portion of the P wave indicating left atrial overload. So this person may be having some amount of left ventricular dysfunction. No significant arrhythmia is seen here. It is sinus rhythm and the heart rate is also normal, below 100. This is another ECG showing anterior wall infarction. There is some difference in the pattern. You can see that the ST elevation is maximum in V4 and lesser in V3 and V2. V5 also shows significant ST elevation. There is ST elevation in V6 and the Q waves are seen in V1, V2, V3, V4, V5 and even here there is a slightly broad Q wave. Pathological Q waves should be at least one division, 40 millisecond. The width is more important than the depth. Depth, we say that it should be more than 25% of the ensuing R wave. Then there is ST depression in 2, 3 and AVF that we usually call reciprocal ST depression in another territory. But that could also be due to ischemia in that territory. That's a never-ending debate whether it is ischemia at a distance or purely electrical reciprocal ST depression. And another interesting feature here is after the Q, there is a terminal R wave, which is not there usually. So this is QR pattern. We'll also call it as QRBBB. This is a manifestation of right bundle branch block, fairly common complication of anterior wall infarction. Because septum is involved, right bundle branch can be damaged. And when there is damage, that usually means more extensive infarction and poorer prognosis. You can also note that there is more prominent negative T in V1, indicating left atrial overload. It is also called left atrial abnormality sometimes, and left atrial enlargement. Abnormality because this is an abnormality in the ECG. It may not always mean left atrial enlargement. So three terminologies are used for the same thing. And why there is initial Q? Usual RBBB shows RSR prime pattern. But when the initial R wave is knocked off by a septal infarction, it starts as a Q and followed by delayed activation, that is slurred R prime wave, that is QR pattern or QRBBB in anterior wall infarction with right bundle branch block. The corresponding change you can see here, slurred S wave in lead 1, that is also part of right bundle branch block. The slurred S wave can also be seen in V6. So this is anterior wall infarction evolved because it is almost getting inverted, but it's probably not that evolved. Fairly early, high ST elevation is seen. T is not fully inverted. Probably this is more of a hyperacute phase. Here it is almost horizontal. I would have expected upwards. If it is truly hyperacute, slightly beyond, something between the evolved and hyperacute, I would say. T inversion in V1 cannot be taken as because of evolution. It could be secondary T wave change of right bundle branch block. Conduction abnormalities also can cause T inversion. T inversion in V1 is also seen in right bundle branch block. Then in addition, there is another abnormality here. You can see this is a premature beat. Premature beat having same morphology as the previous beat. So it is likely supraventricular. And the P wave, there could be a tiny P wave here, but not very clear. So this is a supraventricular ectopic, showing RVP pattern because RVP is there already, and that's followed by a pause. So even though atrial arrhythmias may be considered less dangerous, in the setting of acute myocardial infarction, they are more significant. Atrial arrhythmias indicate atrial dilatation, left atrial dilatation, as we have already seen here. Left atrial dilatation occurs due to left ventricular dysfunction. So presence of atrial arrhythmia should warn you that the person is going for left ventricular dysfunction, and you may even anticipate acute pulmonary edema or heart failure. So atrial arrhythmias have due significance in acute infarction, even though we often are more worried when we see the very wide QRS complex of ventricular ectopy. That is easy to see. Yes, they are also significant. They can go in for ventricular tachycardia and ventricular fibrillation. Unlike the previous two ECGs, in which the features of ST elevation myocardial infarction were quite striking, this ECG can be easily passed off as normal. But you look at more details when there is clinical suspicion of myocardial infarction. You can see that there is minimal ST elevation here, not enough for the usual criteria of ST elevation, and here also very minimal. But there are Q waves here. This is a Q wave in AVL and a small Q in lead 1. This is a high lateral myocardial infarction, but the findings are very subtle and difficult to diagnose with this ECG alone unless you have other evidence like typical chest pain, enzyme elevation, probably wall motion abnormalities on echo. And this ECG also gives another finding which is of relatively recent description. We know that ECG was started how long back? 125 years nearly, 1.25 century back. But acute myocardial infarction diagnosis did not come at that time. ECG diagnosis of acute myocardial infarction was only later on. Anyway, this is another recent finding. That is, you can see a notching in the QRS here. If it is in a person with atrial septal defect, we would have called it as Crochet sign in atrial septal defect. You can see notching here also. This is also notching, the downslope as notch. These notches in the setting of myocardial infarction, they are called as fragmented QRS. Fragmented QRS. That is abnormal conduction occurring in the ventricles. Fragmented QRS is a recent introduction, maybe a decade or a little more than that, and they have significance in that they indicate abnormal conduction and they are prone for arrhythmia. Even though this is a very subtle finding, those persons have a higher risk of ventricular arrhythmias. So ECG, to sum up, is very useful in diagnosis or rather confirmation of acute myocardial infarction, and it is widely available, very minimal expense.